like to welcome you to the new options for gastrointestinal cancer therapy talk. And we're delighted to have learners both join in person and also via the Blue Jeans webinar. So today's presenter is a gastrointestinal oncologist and clinical researcher at Stanford. He is the Colleen Haas Chair in the Stanford University School of Medicine. Please welcome Dr. George Fisher.
Thank you. Oh, man, that's a picture from that's 30 pounds of 20 years ago. All right, I like that. Okay, so I was actually first asked to talk to you about targeted therapies, molecular therapies, and immunotherapy. And so I'm going to spend 1 minute, maybe two, on the molecular therapies, just to let you know that we're still marching along that effort. That was sort of the dream cure of the year 2000. All we need to do is read the DNA, and then we find out. Then we tell the pharmacist which drug to pull off the shelf and say, that's the one for you because we found the DNA defect that drove your tumor. Hasn't quite turned out to be that easy. It does work in some tumors some of the time. But clearly in the last 5 and 10 years, the most exciting thing going is immunotherapy. So I'm going to go focus on that. In terms of molecular therapies, I just came from a cancer research meeting in Washington, D.C. last week. And it's really very exciting. We're learning more and more about the different genes that drive cancer. And we're learning more and more about different ways of inhibiting those genes. But, the cancer cells are just too damn smart. If you block one gene, the cancer cell will either find a way to mutate that gene so you can't block it anymore, or it'll find an alternative path for it to grow. So the cancer cells, just like Darwinian evolution, they can evolve to become resistant to our chemotherapy drugs and unfortunately also our targeted therapy drugs. So for colon cancer, we've known that RAS mutations tell us that there's a whole class of drugs that don't work for those tumors. But for RAS wild-type tumors, there are drugs that do work for those types of tumors. And we've known that for 15 years. The newest thing on the block, and it still hasn't been approved by the FDA, are new treatments for HER2-positive patients. Turns out about 5% of colon cancers are HER2-positive, maybe 10% of left-sided colon cancers, so left and right a little bit different. And we check that for that routinely now at Stanford. And if there's a HER2-positive trait, a HER2-positive cancer, we have clinical trials, or sometimes companies are kind enough to give us their drugs for that. So these are drugs that are used for breast cancer because that's the more typical HER2-positive cancer. It worked very well for breast cancer. Who would guess? It works very well for colon cancer too. BRAF is a similar story. These are tougher tumors, and we have just brand new treatments that have been working for them. And I can imagine that sometime in the next year or 2 years, we'll have an all-targeted therapy and do away with some chemotherapy for some of these diseases. The most exciting thing, and this nice segue to the next slide, is the MSI. Now, MSI and Pol E and Pol D, this represents maybe 3 to 5% of metastatic colon cancer patients. And this represents 1%. But it's a very important 1% because these tumors have significant defects in the ability to repair DNA. So if you think about it, if your tumor cells can't repair DNA, then they're making lots of mistakes that end up being translated into abnormal-looking proteins. Because the DNA is the blueprint for the proteins, and if there's lots of mistakes in reading that blueprint, then you end up with defective or malformed proteins, some of which look foreign. And if they look foreign, the immune system there it can recognize it as something it should react against. And these drugs are enormously effective against this group and very effective against that group of patients. So that's the newest in targeted therapy. But really it's immunology. But immunology is really hard to describe. And so for the 20 minutes I have, I think I have to spend 10 minutes at least just telling you about the immune system. Everyone has a concept of immune system, and patients will often come up and say, just give me the vaccine for cancer. That's all I need. Vaccines work for other diseases. Why don't they work for cancer? Well, we know that the immune system is designed to detect foreign molecules. What does that mean? It means a molecule that's not imprinted as self. It's a molecule that you don't make in the body. And the immune system has this amazing capacity to recognize lots of different foreign molecules, not all, but lots of different foreign molecules. And so Why do you want to recognize foreign molecules? Primarily to help fight viruses and bacteria, because they have very different molecules on their cell surface. These are usually proteins. And any protein or any molecule that the immune system is capable of detecting is called an antigen. So the antigens, you'll hear that term a lot in immunology, is just something that an immune molecule or immune cell can recognize as foreign and binds to. So the immune system binds to or attacks, if it's a cell, it attacks and tries to kill whatever has that foreign molecule on the cell surface, or just binds to it if it's an antibody. Now, the immune system classically is kind of divided into two parts. And this was true when I was in medical school, B cells and T cells. B cells are the simpler of the two. T cells make antibodies. Now, I just told you what an antigen was. An antigen is something that can be recognized by the immune system as foreign. Antibodies are just immune molecules that are capable of binding to antigens. So it's a very simple definition. So these cells, their job is to make antibodies to bind to foreign molecules, whether these molecules are just floating out in the blood or whether these molecules are on the surface of viruses or bacteria. T cells are a little bit more complicated. T cells are capable of killing any cell that has a foreign molecule attached to it. So T cells go out on a sort of a search and destroy mission. They circulate through the blood. They start in the lymph nodes. They circulate through the blood. And if they find something that has this same foreign molecule that the antibodies can bind to, then its job is to kill it. Now, that could be a cell, a normal cell that's infected with a virus. And one way to get rid of viruses is not by killing the virus, but by killing the cells that are making the virus. So that's T cells can get rid of infections by killing the cells, even with their normal cells. But it could also be a cancer cell, providing the cancer cell has something that the T cell can recognize as foreign. Okay, I think you're with me so far. Now, it turns out that in the laboratory, we've been able to make antibodies, initially from mice, but now we can make them fully humanized antibodies, so they're just like the normal antibody, and we can make them to anything we want. We can find a molecule and we can make an antibody to it, almost anything. So the question is, how can we use these antibodies to help us fight cancer? Just recently, we've been able to genetically engineer T cells. And that's been a very exciting area of work. That's sort of labor-intensive, very expensive. Whenever you start dealing with cells, it's much more expensive than dealing with what are simple drugs. But certainly showing tremendous results in some tumors. Now, if you have an immune system that is turned on, ready to fight any infection, one of the aspects of being a T cell that's turned on is you become a killer T cell, naturally, because it can kill the cell that has a foreign antigen. And these killer T cells can expand, meaning they can multiply faster than cancer cells can, in fact. They can grow very fast and then go off in this seek and destroy mission. So you can have an army of T cells all looking for anything that has this foreign molecule on it. Well, that could get out of hand. You don't want the T cells to take over the body, so you need something to suppress the T cells. So Mother Nature gave us suppressor T cells. And their job is to dampen the killer T cell response and turn it off. Right? So a researcher, I hate to admit it, but at Cal, came up with this drug here, ipilimumab, which could block a T suppressor cell. And in the mouse models he was studying, showed that, well, some of the animals could then have their tumors disappear just by blocking this. When this was tried in melanoma, about 14 years ago now, some of the melanomas disappeared in patients. Now, that was shocking. It wasn't shocking because this drug worked. That's nice biology. But it was shocking to all of us who were naysayers in terms of the importance of the immune system. I was always a chemotherapy guy, and then I was a targeted guy, and I didn't think the immune system had anything to do with cancer. But I was dead wrong. Turns out that if you just take the brakes off the immune system, in some cancers, the immune system can go ahead and get rid of that cancer. We never thought that was possible before. So just taking the brakes off means that there's already an immune response. It's just incapable of doing what it's supposed to do because somebody's applying the brakes. So when we found out that there were brakes in the immune system, then we started characterizing all those brakes, and it kind of became a paradigm shift in how we think about cancer. No longer are we actually aiming at the cancer cell. We're actually aiming at the lymphocytes or the immune cells. So this drug doesn't attach to the cancer cells at all. It attaches to the T suppressor cells and keeps them from dampening the immune response. So now we're going to target lymphocytes. And once we decided to start targeting lymphocytes, people started looking for a bunch of other markers. And the most important marker that was discovered so far, but there are many others still on study, is called PD-1. Now, PD-1 and PD-L1, you kind of do the same thing. PD-1 binds to PD-L1, and when PD-1 binds to PD-L1, it turns off the T cell. So if you can kind of imagine, this is not the greatest cartoon here. This is a T cell. This is your immune cell. Up top left is a tumor cell. And the tumor cell is just sitting there, and it has molecules that are capable of being recognized as foreign. Turns out that those molecules have to be put into this MHC molecule, which is also on the cell surface. So this is the foreign molecule that is capable of being recognized by the T cell. The T cell recognizes that and would go ahead and kill it, but if the tumor cell puts up PD-L1 on a cell surface, and if that binds to PD-1, that turns off the T cell. So this PD-1, PD-L1 is sort of like a switch that is a don't eat me signal. You have a T cell that's ready, primed to kill the tumor cell, and it's ready to go, recognizes that abnormal, but if PD-1 or PD-L1 is engaged, it turns off the T cell and T cell becomes neutralized. No longer a killer T cell. So it turns out that we can make antibodies to this. We can make antibodies to PD-1, we can make antibodies to PD-L1, and we can block this interaction. So if you block this interaction, again, you're taking the brakes off the immune system, and you're letting this T cell do its job and attack the tumor cell. So that's sort of the theory. Now, so one of the key questions that came up is, what are the antigens that the T cell is recognizing? What is the nature, what is the foreignness? What are the molecular features of these antigens that the tumor cell is recognizing, that the immune system is recognizing? Well, it turns out that they tend to recognize mutations. I told you that cancer cells are full of mutations. This is a plot of the number of mutations. So the higher the mutations per cell versus the different types of cancers. And you can see that it's pretty widespread, going from melanoma at the top here all the way down to some of the pediatric tumors, which have very few mutations. What I've put a star by is all of those tumors for which these PD-1 drugs have been approved just in the last 3 years. So it's approved for melanoma, lung cancer, different kinds of lung cancer, bladder cancer. Who knows what's in common with melanoma, lung cancer, and bladder cancer? Thing that's in common is that they're cancers that arose from high mutation frequencies. They arose from carcinogens. Melanoma from ultraviolet light, and these are smokers' cancers, bladder and lung cancer. So those, just in the course of acquiring those cancers, of developing those cancers have a lot of mutations from the sun and from smoking that gives them a high mutation rate, and they become perfect examples of how high mutation rate can lead to a higher number of antigens, and the immune system recognizes those antigens, but can't work if there's PD-L1 there. So we just block PD-L1 and those tumors shrink. Now, what I put in boxes here is my job. I work on the GI cancer, so colon, esophagus, stomach, pancreas. The pancreas is way down here, and we don't have a drug for pancreas cancer yet. But this, we think we should have some, particularly for maybe the top of these. You can see the subset of colon cancer here, where there's lots of mutations. That's a different subset of disease. That's called MSI colon cancer. And the MSI colon cancers are cancers that have tons of mutations. So the theory now, I'm going to take one more step and say, well, the mutations that encode proteins can be recognized by the immune system. And therefore, the tumors that have the most mutations should be the most immunogenic. We should be able to get responses. And so the tumors that have inherited defects in the DNA repair, where the tumors cannot repair the DNA, they should have thousands of mutations. And indeed, this class of defect has tens of thousands of mutations. So we did a study with Hopkins, and this is a study where we looked at colon cancers that had defective DNA repair with thousands of mutations, regular colon cancer, which does not have that many mutations, and then other cancers which had thousands of mutations. And what we found was that, and these are all patients who had prior treatments and had no further treatments, no further standard treatments available to them. We had a very high response rate, but an even higher control disease rate. So 90% of patients had good control of their disease. That means their tumor either shrunk or didn't grow, and sometimes for quite a while. But what was also interesting is we had the same results in the non-colon cancer group that had the DNA repair defect. So about 80% of other cancers, which included pancreas, gastric, bile duct, small intestinal cancers. This is unbelievable because there's no chemotherapy drug that even gets close to this for those cancers. So this was a major finding, and that's in front of the FDA right now to get approval. These are CEAs. People know that CEA is a tumor marker, like PSA is for prostate cancer, CEA is for some of the GI cancers. And you can see how rapid the drop is and how prolonged the drop is. And this is looking at actual individual tumor measurements. And what's green is all the MSI tumors. What's red is the normal colon cancers. So you can see the majority of normal colon cancers actually grew. Anything that goes below this line means the tumor shrunk. But look at this. This is 730 days. That's 2 years plus. So that these tumors shrank and they stay shrunk for a long time. It's really gotten us to actually consider the word cure, which we don't really use as often as we like. But some of these patients who get this therapy, we can't say they're cured because we've only had this particular trial for 3 years. But some of these patients are in complete remission for 3 years. It's quite remarkable. Well, so that's the most sensitive among the GI. In fact, that's the most sensitive of the tumor types of all cancers. That people hear about melanoma and lung cancer, as I showed you, but actually the MSI GI cancers are the most sensitive to this immunotherapy of all. But it does work in other GI cancers, not to the same dramatic effect, but it does work. And so when we talk about response rates here, I mean, we're talking about the percentage likelihood of shrinking the cancer significantly. And we can see for esophagus, gastric, biliary, liver, primary liver cancer, anal cancer, they're all reasonable response rates. And all of these diseases are now in randomized clinical trials trying to get FDA approval, with right now 5 different companies vying for this competition. In fact, as of last week, there were 21 PD-1 and PD-L1 drugs in development. So it's a lot of stiff competition in this field. But they're not all winners. There are some losers in the game. It turns out that we haven't seen any significant response rate for the PD-1 drugs by themselves for pancreas cancer. And for the normal colon cancer, we haven't seen. And I'll remind you, even I would say the same for about 70 to 80% of these other cancers. So 20 to 30% is nice if you're in 20, 30%. But if you're not in that group, your tumor grows. And why does it grow? And what can we do about it? So now we're going to get a little bit more esoteric. These are the winners. This is such a dramatic effect that the FDA will approve this without any further study, I'm confident, because this would be like doing a randomized trial with a parachute. You don't do that, right? And so these patients have such dramatic responses that the FDA will just approve it, which they don't do very often. So how can we make winners out of the losers? What can we do? What's different about their tumors that they're not responding? And what sorts of interventions can we have to make them look more immunogenic, make them look tastier to the immune system? Well, we can sometimes give a short burst of radiation. Radiation can cause mutations, can change the environment of the cell, can kill some cells, and sometimes just killing cells will unmask mutations. Unmasking is a bad word these days. But you can just reveal mutations that were not otherwise visible by giving a short burst of radiation or by killing a number of cells. I'll mention dual checkpoint blockade briefly because I just mentioned these are called checkpoint inhibitors. These are drugs which block some aspect of the immune system so that the other aspect of the immune system can work. This is a list of checkpoint inhibitors that we have drugs for already that are in clinical trials. And in fact, Stanford has done clinical trials with CD27, CD28. We're opening one with CD40. We have some in the laboratory that OX40. These look very promising in clinical trials. We don't have them at Stanford yet. And CD47, which is up here, is a Stanford-born product. This was a Stanford product that's going through clinical trials. So lots of exciting opportunities in this idea of checkpoint inhibitors and how do we combine them to the best advantage of getting an immune response. But then there are things like vaccines, there are bacterial vaccines. So I'm just going to spend a minute talking about some of the more complicated ways of trying to get the immune system engaged. Genentech, we're doing a trial with Genentech with an antibody. Again, so an antibody is just a drug that can bind something. And instead of binding one thing, these bispecific antibodies can bind two things. So the bispecific antibodies can bind one thing on one side of the antibody and something else on the other side. These things are always kind of a Y-shaped molecule. And so Genentech designed a bispecific antibody that can bind the tumor cell and can bind a T cell. And much to everyone's surprise, as simple as that sounds, putting those two together, forcing a root introduction of the tumor cell and T cell, the tumor cell loses. The T cell gets activated when it gets that close to a tumor cell and can go ahead and kill the tumor cell. So it doesn't matter whether this binding occurs in the tumor. Then you have this thing attached to the tumor, and this end here just kind of hanging out in the blood. And then anytime a T cell comes through the blood, it binds to it, sticks to it, puts the two together, and the T cell kills the tumor cell. Or you inject this in the blood, it might. I'm sorry, I got this wrong. Yeah, no, it might bind the T cell. So it might just grab on the T cell, and then as the T cell just kind of randomly goes through the blood, at some point it'll encounter a tumor cell. When it cruises by the tumor cell, it binds the tumor cell, and now you put them two together, and the tumor cell loses. So it's a way of forcing the introduction of tumor cells where some tumors just don't have enough T cells in them. This is a slightly more complicated way. I'll go through this side first. This is sort of using bacteria studying the immune system and hoping that you can trick it into recognizing something that it shouldn't. Okay, so I'll start by saying that mesothelin is a protein or an antigen that's on the surface of most pancreas cancers, most gastric cancers, not as many colon cancers, but a lot of ovarian cancers. So this is on the surface of the tumor cell, and the problem is mesothelin is a normal protein. We all have mesothelin on some of our cells. So why would you attack that? Well, you attack that because there's actually more mesothelin on those cancers than there are on the normal cells. So maybe you can get a little bit of a therapeutic advantage by attacking something that has a higher concentration in the tumor cell. But it's normal, so you can't get the immune system to react against it. Aren't they're primed to kill mesothelin, to trick them. So the outcome is to take the bacteria in your body. And there are a lot of bacteria, but Listeria is the one that every once in a while you hear Safeway had to clear all the milk off the shelves because there's a Listeria outbreak at the farm. Or all the ice cream disappears for a while because Listeria was at the dairy. So Listeria is one of those bugs that makes you sick as can be. You get fevers, chills, sweats, you feel worn out. It's like a really bad flu. And if you get really bad Listeria infections, you can die, particularly if you're sick to start with. So Listeria is a serious bug that causes a very rapid immune response, a very intense immune response. Well, what this company did is they got rid of two of the Listeria genes that were essential for reproduction. So now you have a bug that can't actually cause an infection, but it can make you sick as hell while the bug's in your system, but it can't propagate. So you go ahead and give this Listeria that's sort of decommissioned in terms of causing a serious infection, but you also genetically engineer it to produce mesothelin. So now all of its surface is covered with mesothelin. So now you're given a drug, the immune system attacks it voraciously. The bug disappears because the immune system's good and it can't reproduce. But in attacking this immune system so vigorously, some of those immune cells start recognizing mesothelin as foreign. And then they're on the seek and destroy to go kill anything that has mesothelin on it. So this is sort of using the listeria as a Trojan horse to try to find a way of tricking the immune system into attacking mesothelin-containing cells. So it's always more complicated than I can tell you in one 20-minute session. But we have the regulatory T cells. These are the T suppressor cells that can turn off the immune system. We have dendritic cells I didn't mention. These are the suppressors of the immune system. These are the cells that are responsible for educating T cells as to what to recognize. So these cells will pick up bits of foreign molecules and then process them and teach T cells what to recognize. We have macrophages, which are kind of the dump trucks of the immune system. They go out and kind of pick up dead cells, dead or dying cells. A famous lab here at Stanford, Merv Weissman, has found that tissue macrophage can actually kill tumor cells, and so we have checkpoints on macrophage that we're blocking and allow them to kill tumor cells. And then we have tumors in normal tissue, and it turns out that these things are constantly communicating with each other through these proteins that tell them, okay, I'm normal, so don't touch me, or you can't touch me, so don't eat me. So even though they look tasty, and these interactions we're just starting to learn. We have drugs to each and every one of these molecules.
Okay, so our next speakers are Stanford Cancer Clinical Trial participants, Eve and Rich.
I'm Eve Bukowski, and even though I have cancer, I consider myself one of the luckiest people alive. I have a chance of living for a long time with this disease because the doctor that you just heard from and others throughout the country are dedicated to research and innovation that is making hundreds of thousands of people believe that miracles do happen. But I know it's not a miracle. Faith is a key component, but it's faith in science, discovery, and innovation that keeps you motivated and enables me to have one of the finest research institutions, which, as you all know, is Stanford, and the fabulous Dr. Fisher on my side to make sure that I have access to the latest therapies. For those of you who don't know who I am on my 9th year of battling stage 4 colon cancer. And over these past 9 years, I was lucky enough to participate in not only one, but 2 incredible immunotherapy trials. And I don't need to go into immunotherapy because, of course, Dr. Fisher just walked through it. But what's been fortunate for me is that rather than poisoning my body, I've gotten the chance to actually harnessing my own body's my own system to fight the cancer. I haven't had to go through, I haven't had as much poison as I guess I could have had if I was just going straight chemo throughout the whole thing. But let me take you back a step in my journey because I haven't always considered myself lucky. In fact, just 9 years ago, I felt like the unluckiest person alive. Susan Sontag, an author, activist, filmmaker, and fellow cancer sufferer, once said, "Everyone who is born holds dual citizenship in the kingdom of the well and in the kingdom of the sick. Although we all prefer to use only the good passport, sooner or later, each of us is obliged, at least for a spell, to identify ourselves as citizens of that other place." My passport to that other place was stamped in 2008 when I went to Iowa to campaign for Hillary Clinton during the famous Iowa caucus, the start of the true campaign season. Instead of making it to the actual caucus, though, I found myself at Mercy Hospital in downtown Des Moines in excruciating pain. I had no idea what a difficult road lay ahead. Doctors found a blockage, and I was facing immediate surgery. 2 days later, I woke up to a diagnosis of colon cancer, and it had spread. Alone and far from home, I had only my fears to keep me company. That fear provided momentum for a crusade of sorts. I was diverted from campaigning for Hillary Clinton to campaigning for my life. Over the next 9 years, I had 36 surgeries, including I'm not even going to go into all the things that I had, as well as 3 rounds of radiation. I've had fistulas, I've had chemo, I've had it all. Statistics say I should no longer be here. I read recently that fewer than 4% of the patients who are diagnosed with metastatic colon cancer live 3 years. But I'm now on year 9 and still in full battle mode because people are not statistics. As you may know, each body reacts differently to disease and the drugs that are used to treat the various diseases. In fact, at my first appointment with Dr. Fisher, he told me to avoid looking at statistics because statistics just weren't relevant. But now comes the best part of my story, the part where the latest innovation by the remarkable research institutions and biotech companies played a critical role. About 6 years ago, I had a splenectomy to remove the cancer in my spleen. The surgery went well, but just 2 months following the surgery, I went in for a new baseline CT scan, and the cancer had come back in force. Dr. Fisher told me that my only alternative might be to revisit chemos that hadn't worked well for me before, and some had, and the situation, though, looked very dire. That night, as I drove home, I wrestled with how I was going to say goodbye to my husband and my twin daughters, who were just 8 years old at the time. My daughters were only 4 when I was originally diagnosed, and living with a mother with cancer is all they've ever known. Up until that point, I had always had another option, another chemo that I hadn't tried. I always had a plan. I'd hoped that perhaps the next treatment would be the one, and that I would be able to hold out until a cure was found. Well, this new diagnosis from Dr. Fisher, along with his statement that we had tried pretty much everything, took me by surprise. Maybe I wouldn't be around for the girls. Well, throwing in the towel was not my MO. What options did I have? My plan had dissolved like the memory of a dream. But life can throw you an unexpected Hail Mary. The next night, I was supposed to speak to the American Cancer Society volunteers about hope, which is pretty ironic. How was I possibly going to talk about hope when mine was gone? Unbeknownst to me, Dr. Fisher was the other speaker on the program that night. And when I saw him, he looked at me and he said, "Eve, I think I have something for you." When I pressed him to tell me what he had, he told me to just wait for his speech. When it was his turn to speak, he talked about a new study with Genentech, and he's kind of talked about this a little bit earlier today, which would test immunotherapy on different cancers, including colon cancer. And it was called anti-PD-L1. As he was sitting down, he turned to me and told me that that's what he wanted to try on me. And that was it. In less than 20 seconds, Dr. Fisher restored my hope, and my will to fight returned with a rush of anticipation. Suddenly, my mind was racing with plans. Maybe I could plan again. Maybe I would live to see my twin daughter's 10th birthday, maybe even see them walk down the aisle. I was able to stand up and give my speech on hope. Following the speech, I turned to him and asked why the heck he hadn't mentioned the study the night before. His response, he had just finished inking the deal with Genentech on that very day. And for the next 3 years, I was privileged to be a pioneer, and some might call me a guinea pig, in determining the efficacy of immunotherapy for colon cancer. Unfortunately, it didn't last forever. My cancer numbers started to rise once again after 3 years, and Dr. Fisher, wanting to be cautious, decided to take me off of the study. I returned to chemotherapy, but it was a new chemotherapy, one that hadn't existed when I began my immunotherapy trial. And it was because I was able to stay alive on that trial for 3 years that other breakthroughs were able to happen. So my goal, which from the beginning was just to stay alive until the next big breakthrough was working, had so far proven to be working. 7 months ago, I got the call again. The immunotherapy trial that I've been hoping to join had finally had a space available. So I got off the chemo, did the qualifying test, and began my newest immunotherapy trial at Stanford. What's so exciting is that we're just at the beginning of this new world. And as I said earlier, it's a world where we no longer have to poison the body to get rid of cancer. We're a world where the person's body is actually a pioneer in fighting this terrible disease. And our research institutions, in coordination with biotech companies, are restoring hope through innovation. These partnerships are creating, if not miracles, miraculous treatments that are allowing people to live better lives and often live instead of die. And for those of you who have cancer, I hope it's not very many people that are standing there, but it's not very easy living with cancer every day. In fact, it's exhausting. For more than 9 years, I've lived my life in 2 to 3 week and 2 to 3 month increments. Every 3 months, I get a CT scan to see what's inside. And like everybody else, I hold my breath for days. Those are days that take me away from enjoying time with my daughters, days when I question if I'm going to be around to see them go to the prom or get married. Fighting cancer, as many of you know, is a mental challenge as well as a physical one. And knowing that there are new discoveries on the horizon gives cancer patients the strength to keep on fighting. And for those of you who have not had cancer, let me tell you what it's like to tell people that you have cancer. It's devastating every single time. And you try to be nonchalant because you're sick and tired, and many times literally sick and tired of the tears, the hugs, the I'm so sorries. You can't help but notice that look. It's a look that says you're about to die. And it's the fear that flows out of everyone that I tell that takes my breath away. And yeah, after 9 years, it still continues to overwhelm me. But here's what's different about my cancer. Throughout my trials, I've looked totally healthy, and I got to tell people about my immunotherapy. And then the conversation shifts. It shifts to how I'm fighting and how I'm winning. And when people see a tangible example of how I've successfully taken on the battle with cancer with my immunotherapy partner, they seem to have more confidence in me and my ability to win the war. And when others believe in me, it makes it all that much easier for me to believe in me. So I feel like I've renewed my passport and I'm traveling back to the world of the well. Unfortunately, my journey is not yet over. Dr. Fisher gets to continue to deal with me. About 2 months ago, I had to come off my wonderful trial and begin chemo once again. But I'm anxious to get on a new trial. And I'm enthusiastic about doing this, and not just for me, but for those who will come after me. This is my opportunity to help not only me and my family, but contribute to scientific advances so that others who come after me will have more options. So many others participated in trials over the decades before I got cancer, and it was their willingness to test new treatments that enabled me to live for the last 9 years. And how often, I was thinking about this earlier today, how often do we get the opportunity to truly impact the world in a very significant way, one that can lead to actual lives saved? Well, this is our chance. And I just hope that what scientists have learned from me and those that come out will help those that come after me. That someone else will be able to see their children grow up because I and so many others were willing to try something new. The science and innovation that is currently taking place in life sciences have given me and fellow patients an incredible gift, the gift of life, but not just life, but quality of life. We have been given the opportunity to spend more time raising our children, loving our spouses, and participating in the world around us. And Stanford and other research institutions give us hope, and they give us courage, and they allow us to dream of the future. And for that, I will be forever grateful. And of course, my favorite person on the planet, besides my family, is the man who's there today with you, Dr. George Fisher. And that's pretty much what I wanted to say today. Thanks.
Okay, hi. I'm Rich Valdez. About a little over 4 years ago now, I was diagnosed with pancreatic cancer. Fortunately for me, the tumor was on the tail of my pancreas, so I was eligible for the surgery, which I had, and I went through chemo, radiation, and more chemo. And then after 6 months, the tumor went away. I was cancer-free. And during that time period, I participated in my first clinical trial for Dr. Fisher, and that was for a vaccine provided by Aduro. And it was intended to prevent the cancer from returning. Well, after 6 months, it came back, and it landed in my liver and about 11 tumors in my lungs. And that was about 3 years ago last month, and I was given maybe 12 months. So at the time, I just had the chemo options, and we elected to go with the most toughest and stringent one, and that was FOLFIRINOX, made up of 3 different cocktails. And highly toxic, but it was effective. And after about a year, the tumor in my liver went away, and the tumors in my lungs went down from 11 to 7. But I had to take a break. By then, the peripheral neuropathy had numbed my feet, fingertips, and a little bit of my mouth. So I needed to take a break from it. So we took a 3-month break. Unfortunately, the cancer decided to party during that time break. And when we did my 3-month CT, it was back in my liver and back up to 10 tumors in my lungs. But at that time, another clinical trial became available. And that's one of the immunology trials where the bacterial Listeria was involved, a vaccine GVAX, nivolumab, the whole 9 yards. So I did that trial for 3 months, had my check with the CT, and unfortunately, on my second clinical trial, this one also did not work. It did not work at all. In fact, the cancer took this opportunity to spread to my gallbladder, stomach lining, and lymph nodes, in addition to the liver and the lungs growing. So then it was pretty dire. Back to counting the months again. So that was a little over a year ago, and I started my third chemotherapy, and this time it was the Gemzar and Abraxane. And been doing that for about a year, and during that time period, I got better again. The tumors in my gallbladder went away, the stomach lining went away, one of two lymph node cancer tumors went away, and the liver and lungs tumors all shrunk. And that's where I'm at today. So even though I've been unsuccessful with clinical trials, 2 of them now, I'm not discouraged whatsoever, because I know more often than not, clinical trials are not always successful. So I'm counting on third time being a charm. In the meantime, I'm counting on the chemo buying me the time to hang in there long enough to be ready for Dr. George Fisher's next miracle clinical trial that this time I firmly believe will knock the cancer out of the ballpark. So I'm not at all discouraged, even though I've been through 2 that didn't help. But with the latest, the treatment that I've been receiving from Stanford, I can't complain one bit. Like Eve, I look at it as a blessing. It's been an opportunity for me to be an advocate. I've been an active member of PanCan, done several years now of fundraising with Purple Stride, and we raised over $15,000 the last 2 years for more funding for research for cancer. In Washington, D.C., knocking on my representative and senator's doors, making sure that pancreatic cancer gets its fair share of funding from the government, and doing whatever I can to spread the awareness. As long as I'm fit and healthy, like Eve, it doesn't really show. There's no pain involved or anything like that. It's just what, how you feel with chemo. The poison, as Evie calls it, Eve calls it, because it does kind of knock you out. But other than that, I'm ready to trudge on and just wait on Dr. Fisher's next clinical trial that he might have for me. That's it for now.
Okay, so before we begin the question and answer portion of the talk, I'm going to review some information resources that may be of interest. And we have some handouts back there, by the way. So first of all, how can you find cancer clinical trials at Stanford? You can visit our site, cancer.stanford.edu/trials, and conduct keyword searches and browse conditions and eligibility flowcharts. And the handout in the back has information on that. You can download the Stanford Cancer Clinical Trials Search app, available for free on iTunes and Google Play. And you can also contact the Stanford Cancer Clinical Trials Information Service. Now, for studies available at other institutions, you can find information from the National Institutes of Health at clinicaltrials.gov, the National Cancer Institute at cancer.gov, and the American Society of Clinical Oncology at cancer.net. And if you have a general inquiry about cancer clinical trials available at Stanford, an information specialist can help you identify trials available, provide you with the study contact for the clinical trial, provide you with the new patient coordinator contact, explain what to expect if you would like to enroll in a study, and send you information related to your inquiry via email or postal mail. And now for assistance with general resources for your cancer information search, we would like to suggest the Stanford Health Library, where you can get help from a health librarian at 4 different locations. They provide free, customized literature searches for your medical or health-related questions. Also, the National Cancer Institute has a cancer information specialist who can help you with a variety of your cancer-related questions, including assisting with clinical trial searches. Services are free and anonymous. And lastly, cancer.net provides comprehensive oncologist-approved information from the American Society of Clinical Oncology. Also, if you're interested in receiving Stanford Cancer Clinical Trials event notifications, consider subscribing to our email list. And you can subscribe online at cancer.stanford.edu/trials. And on the website, you look for subscribe to events, which is underneath need for help finding a trial. or for those who are here today, you can come see me directly and sign up at the end of the talk. I have stage 4 colon cancer. I need stronger glasses.
I have long arms. So finishing chemo, oncologists recommend doing radioembolization on liver starting malignancy. Okay, so this is sort of a specific standard of care question. Anyone who has stage 4 colon cancer gets chemotherapy. Sometimes the chemotherapy stops working, or sometimes you just need a break from chemotherapy, and you still have liver spots. And so the question is, can we do something besides chemotherapy for liver spots? And yes, there's something called chemoembolization or radioembolization. Long words, but basically, if you can remind yourself that cardiologists routinely put a catheter down here in this artery down by your leg, and they're able to thread that catheter all the way up through the large aorta, and then into the heart, and then into tiny vessels in the heart to open up a blockage or to squirt some anticoagulants in there. They can do amazing things with these tiny catheters. Well, we can do the same thing in the cancer world. We can put a catheter the same way, except instead of going all the way up north to the heart, we take a quick left turn, and all of a sudden we're in the liver artery. Turns out that most cancers get their blood supply from the liver artery, whereas most normal cells in the liver actually get the blood supply from a different circulation called the portal vein. So because there's preferential circulation from the artery, and because you can access the artery through a fairly simple procedure, you can squirt nasty things right at tumors. And these nasty things tend to be in 2 categories. They tend to be either little beads that are coated with radiation, so you're sort of hand delivering radiation to the tumor, or they're little beads coated with chemotherapy that then the chemotherapy kind of leaches out. The nice thing about that is that it has very little systemic effects, so you're really concentrating on your effect on the liver. So if you have liver only or liver dominant disease, that's actually a very reasonable treatment option. We also have clinical trials for people with liver metastases, so that's another option. We have one trial that's specifically for people with liver metastases, where we're giving a drug that we hope will disrupt the blood vessels in the tumor, and we're using a new technology to measure that, contrast-enhanced ultrasound, which is very simple, taking a microphone with some jelly, just like you do when you're checking out a fetus. But you can go ahead and look over the tumor in the liver, and you can measure the blood flow in the tumor. And so we're seeing whether this new drug alters the blood flow in the tumor, and then secondarily, if it does alter the blood flow, whether that correlates with what the next CT scan will look like. So trying to draw a similarity. So that's a clinical trial. The imaging part of that clinical trial is just to learn about better ways of imaging and predicting how tumors will behave. It's not really a therapeutic part, but it's aligned with a therapeutic trial, with an experimental drug. So radioembolization, which is the trade name for that type of procedure where we put the beads in the liver, that's perfectly fine.
Okay, our next question is high MSI the same as Lynch syndrome?
Not quite, but it's close. So I talked about MSI high tumors. MSI, it stands for microsatellite instability, which is a terrible term, but what it means is that the DNA is making there's lots of damage to the DNA, and the MSI is just one way that we detect that damage. Turns out that the link here is that when you have microsatellite instability, it means that you're missing an important DNA repair protein. Now, you may be missing that protein because your mother or father had a mutation in that protein, and you inherited that mutation. And so your tumor's not making a good DNA repair protein, and your body's not making it. In fact, that's how you got the cancer in the first place. So people who have MSI Lynch syndrome tumors tend to be diagnosed at an earlier age because they're already very susceptible to cancer. They're prone to higher mutations. And not just colon cancer, but also for gastric cancer, small bowel cancers, ovarian cancer, and uterine cancers. So that the lack of a protein can be inherited as a genetic defect, and we have genetic counselors who can help with family counseling for that. But more commonly, the MSI group is actually through an event where the gene is silenced. So the gene sequence is perfectly fine, but it's not expressed, meaning the gene is turned off by mechanisms that we still don't fully understand. So about 2/3 of patients who have MSI tumors don't have the inherited gene. They have genes that are just turned off. But their tumors are the same in terms of acquiring all these mutations and therefore being potentially mutagenic.
Okay, our next question. How do you monitor your patient's statistics real time and correlate chemo dosage to cancer cell death real time?
Yeah. Well, we don't. It'd be nice if we did. There are lots of different ways of. So ultimately, what's our goal? Ultimately, our goal is to allow a cancer patient to have a better quality of life with more time. Okay. And when we hit the home run, that's secure, providing we haven't done too much damage, so that we haven't compromised too much quality by overtreatment. So that's the goal of all of our treatments. But then we can't always measure that so accurately. So one way we measure that is on CT scans. So we'll get scans every 2 or 3 months, and as long as that tumor is not growing, and as long as the treatment is not causing too much of an impact on quality of life, we say, well, that's a win. It's even a better win if the tumor is shrinking and the treatment's easy. If the treatment's tough and the tumor's not changing, then we have to step back and say, well, maybe that's not the right treatment for this person, or maybe it's time to take a break, or maybe it's time to look at something different. So this is a sort of a reiterative process where every 2 or 3 months we sit down with the patient and we look at the scans. Now, what we really like to have is something that predicts what the scans will look like. And that's why we're doing that ultrasound test, because if we can do an ultrasound before treatment and then look at the changes 4 hours later after receiving the drug, and if that correlates with what the scan 2 months down the road will look like, we might be able to give a treatment, do an ultrasound 4 hours later and tell you, well, this treatment's working, we'll go ahead with it. Or we'll say, well, we're not sure this treatment's working, we think maybe it's time for a different treatment already. So that's sort of in the world of, there's an enormous amount of research done around biomarkers. And biomarkers are just surrogates for more important endpoints. So the important endpoints are quality and longevity. And these biomarkers are trying to get an early readout on that. Is the treatment doing what it's supposed to do? Is the tumor likely to die? And so we do that with molecular tests. There's something that people have heard about in the news recently called the liquid biopsy. The liquid biopsy is getting just blood sample, and we can now look for tumor DNA in the blood. The tumor DNA is not doing any damage. It just leaks out of the tumor. And we can measure the tumor DNA in the blood these days and give some sense as to, well, if there's less tumor DNA than there was before the treatment, then that probably means the treatment's working. Right now, that's no better than the CEA or PSA for prostate cancer, but it has the potential for telling us which genes are turned on and which genes are mutated. So when we use it, as I mentioned, the tumors can become resistant to target therapies. We could get the blood samples from patients on target therapy, and we can predict when that target therapy is going to stop working, because we can detect the gene that leads to resistance. So that's another use of the cell-free DNA, the liquid biopsies. And what we always like to do as scientists, we always like to get a biopsy of the tumor every month or two. But most patients don't like that. Most insurance companies don't like that. And so liquid biopsy might be the best that we can do to compensate.
Okay, I have another question. Why are we seeing increased colorectal cancer rates in people less than 40 years old?
Yeah, so nobody knows. There's and this isn't all that new. I know it just hit the news again because there's another paper, but we've known this for about 15 years now. We don't know. It's a starting point. The theories are out there is maybe it goes along with the obesity epidemic. And obesity has really taken over in the United States. In fact, the incidence of colon cancer in Asia is very, very low compared with the incidence in the U.S. But it's rising as rapidly as any other cancer because of westernization of a lot of the Asian countries that are becoming modernized. McDonald's. I mean, I hate to blame a burger. I love burgers as much as anybody else, but that has been the strongest correlation to this at an epidemiological level. And so it really pushes our pushes us to try to figure out, well, what do we do for the younger patients? Because right now you don't start screening for colon cancer until you're 50, unless you have a strong family history or you have some other predisposing problem. And I had a bunch of, it's been some time now, but I still remember I invited 25 patients to go to my house for dinner to talk about colon cancer, and 44 came. So we had to order extra pizzas and have them delivered. So we had 44 people in my house to talk about colon cancer, and 24 of them were under 50, and several were under 30. And so we were talking about trying to get them involved in the American Cancer Society, and they said, no, American Cancer Society says you don't start screening until 50. Why should I do that? So they were with Jane Pauley, who recommended, because her husband died, I think, at 45, colon cancer, trying to get it younger age. What we're trying to do now is we're trying to instead of having one guideline that is supposed to be appropriate for population, is trying to risk stratify. So we can ask the question, well, what is your family history? How old are you? What are your risk factors? And have you had a colonoscopy before? Was there a polyp? And that can determine whether you should have a colonoscopy again in 10 years, or whether you should have it in 5 years, or whether you should have it the following year. So another study that was just done that relates to that, to the age thing, is that at Stanford, we're pretty heavy on doing lots of research with our patients. There was a study that came out of Ohio State where they looked at all patients under 50 and did genetic testing on them. They found that 16% of the patients under 50 had an inherited gene. Ordinarily, we don't really, before that, people in the community were not being routinely tested. Now we test everybody looking for inherited genes, not just because that might tell that person something about their cancer or might give us some insight as to what caused the cancer, how it developed. Most importantly, because if we identify the gene and we check your siblings, your cousins, your kids, we may be able to save lives by preventing cancer. This might be earlier colonoscopies if we found that gene. So really, genetics is really a key thing now, and it's becoming more and more important. Is there another question?
Yeah, this is like a two-part one.
What causes disease to become resistant to immunotherapy? Oh, good question. I was just at this meeting. So it's kind of, I mean, I was contemplating retirement. Worried my wife, but I was actually thinking, I might take up golf or something and trying to figure out what I should do in the last 3, 4, or 5 years of my career. And then I started using this immunotherapy in patients, and there's no way I could retire now. After making people sick for 25 years with bad drugs, that I would hope and pray that the next game would make it worth the trouble I put them through. Seeing tumors that are shrinking with people who look feeling well despite the treatment, it's just changed oncology. So I can't possibly miss out on this part of oncology by retiring soon. So at this meeting in Washington, D.C., where this is all brand new, that tumors are shrinking with immunotherapy. I mean, it's just absolutely amazing. It's a miracle for those who have shrinkage. There are two important questions. One is, why doesn't it work in other people? So what is it about the immune system that's not working in some people? But secondly, when it does work, why does it stop working? Well, there are two parts of that question. One is that it can work even after you stop the drug. So one of our trials is designed for 1 year, another was designed for 2 years of treatment, then we stop the drug. And we have 3 people who are still in nice, sustained control of their disease without any further drug. And that tells us something about the immune system. The immune system can change and react to changing biology. That's what it's intended to do. So you don't always need to sort of stimulate it or to block an inhibitor of the immune system. And we're just learning this because it's all brand new information. There are, however, some patients who will have a progression of their disease during therapy. And so then the question is, how do they become resistant? Well, those antigens that I described, sometimes the tumor will stop making those antigens, or sometimes the tumor will stop making the machinery that allows the T cells to recognize those antigens. Or sometimes the tumor can actually put out little molecules that will recruit more T suppressor cells. and then T suppressor cells come in and they block the killer T cells. So keep saying I have 2 minutes. So you have another
one last question,
one
but
last question.
maybe you can read that.
Okay. Maintenance chemo versus joint clinical trial. So if there's no evidence of disease, we use that term NED. If there's no evidence of disease, then the question is, should you go on maintenance chemotherapy or should you go on clinical trial? It's a good question. We're actually trying to design a clinical trial, a clinical trial just like that for pancreas cancer at the national level, and we haven't quite figured it out yet. But if there's no evidence of disease, and the disease on the CT scan or by labs, you might not need any treatment. Now, that doesn't mean you're cured, because there's still a risk of cancer coming back sometime. But at some point, it's, again, the cost average quality of life, right, over time. Why give somebody a treatment when there's no evidence of disease? We do that postoperatively to try to kill microscopic cells, but we only do that for 3 to 6 months. We don't do that in settings where we've shot our wad, we've given all the good drugs, and right now the person looks pretty good. I say that's a great time for a chemo holiday. And so we all celebrate those chemo holidays, and we hope they last a long time. And sometimes they last forever, and that's a cure. More often, they last for months or a few years, and then the cancer comes back, and then we figure out what's the best treatment then.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.